Welcome to Hypertension Canada's webinar on the Hearts Program, a primary care initiative for Canada. We'd like to begin with a land acknowledgement. As we are located in Toronto, we acknowledge that the land we are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. A few housekeeping items to mention before we get started with today's webinar. All attendees are on mute. If you have a question for us, please send it through the chat section of your Zoom window. Your questions will only be visible to the speakers, panelists, and myself and my colleague Kevin. The webinar content will take about 45 minutes. All questions regarding the presentation content will be held until the last 15 minutes of the webinar when we will open for Q&A. The webinar itself will also be recorded and will be available on our website for people to watch after the event. Without further delay, I will give the floor to Dr. Norm Campbell for the introduction to the webinar.
Welcome, everyone. This is a Heart Symposium in celebration of World Hypertension Day, which was May 17th of each year, including this year. I'm Norm Campbell. I'm the interim chair of the Canadian Hypertension Coalition, and I'm co-chairing this session with Kristin Terenzi, who's a family physician and Hypertension Canada board member. The session today is co-sponsored by the Coalition and Hypertension Canada. It's important that hypertension is the leading risk for death in the world. In Canada, we've had some success. It's the second leading risk for death. Canada has one of the lowest prevalences of hypertension in the world, and it also has the highest rate of hypertension control in the world. And this was attributed to a very extensive education program that started in the year 2000 and ran to about 2011. Unfortunately and sadly, as that program wound down, the hypertension control rates are declining in Canada, and specifically in women, where there was an absolute decline rate of 20%. And this is mirrored by increasing cardiovascular disease rates. For me, hypertension is highly preventable through nutrition policy, with about 80% of hypertension attributed to unhealthy diets. Specifically, about half of hypertension is related to too much sodium in the diet and too little potassium in our ultra-processed diets. Another third is attributed to obesity. That's not the subject of today's conference. It's really about treatment, and hypertension is also highly treatable. The World Health Organization has developed a state-of-the-art primary care intervention that is both more effective, less costly, and builds primary care compared to traditional ways of controlling hypertension. The WHO program was based on a Kaiser Permanente intervention in Northern California that started in about the year 2000. Today, we have 4 speakers. These represent the world experts at population control of hypertension. From the WHO Central in Geneva, we have Taskeen, who's the medical officer responsible for cardiovascular program implementation, and that includes hearts. So global responsibility, spends a lot of time traveling around the world supporting countries. The region of the world that is the most successful, I think by a long shot, in implementing hearts is the Pan American Health Organization, the Americas. And nearly all countries in the Americas, with the exception of Canada, have their national governments engaged in implementing hearts. And we have the reason for that is one of our speakers, Dr. Pedro Ordunez, who has really driven countries around the Americas to action. From Kaiser Permanente, we have the foundation of the Hearts program with Dr. Marc, who developed this program in the early 2000s. And then from our own area, we have Corinne Kristin, who is adapting the Hearts program to the Canadian context with an exciting intervention to bring in home blood pressure measurement into hearts. That'll be the introductions for these world-leading speakers that you're going to hear shortly. This will be followed by a panel discussion with our own Kristin Terenzi, and we're really honored to have Erin O'Neill, who's a new Assistant Deputy Minister for Primary Care in Alberta Health, really responsible for bringing primary care, patching it back up and getting it on its feet. And so they will discuss the different talks that you hear, and then we'll have an opportunity for people to ask questions off our speakers and panelists. So without further ado, let's hear from Taskeen Khan.
Good day, everyone. I'm Taskeen Khan. I'm currently the medical officer for cardiovascular diseases at the World Health Organization in Geneva, Switzerland. And it gives me great pleasure to talk to you today a little bit on the WHO Hearts Initiative and our progress on hypertension control in general. So to start with, and I'm sure many of you know this, hypertension programs remain neglected, under-prioritized, and vastly underfunded. It's quite funny. I often say, and hear people talk about funding gaps. Well, for hypertension, it's actually a funding void. And this is just a quote from Dr. Tedros, our Director General, who maintains that hypertension control programs need to be at the center of universal health coverage. More people die from cardiovascular disease than from any other cause each year. Hypertension affects around 1.3 billion adults globally, and just 4 out of 5 have it under control. And this despite there being cost-effective solutions. So often I hear about integration, about needing to treat lots of conditions, about having large priorities, about things like mental health, communicable diseases, health systems, and all rightfully so. Everything deserves its own place. So why would you start with hypertension? Well, let's talk about some of the key facts. It's the single most prevalent risk factor globally. Treating it has the largest impact on healthier life gained. It requires no laboratory or specialized equipment in order to test. You just need a validated working BP cuff. It's simple to treat. You just require 3 drugs really. The drugs are pretty safe with not much side effects. It's one of the most important interventions for people living with diabetes. It's a pathfinder to universal health coverage. And once we start with hypertension, we can build services to integrate things like diabetes, cancers, chronic respiratory diseases, really one step at a time. So I wanted to share with you from our global report. The first ever global report on hypertension was launched last year on the sides of the UN General Assembly. And it alerted us to the problem that the world is facing and how hypertension is actually a public health problem. And so here I wanted to show you the Canadian hypertension profile. And it's true, Canada has been one of our very good examples of, having a global prevalence rate less than that of the average of the world, of having reached more than 50% control. But there's always better to do, and there's always much to improve. And what we understand from this data is that it's population level data. It's based on modeling and based on estimates, and not necessarily a true picture of what's happening on the ground. In terms of the lives saved arguments, health gains from improved population blood pressure control more than 50% by 2050, you can see that we can avert 76 million deaths. In order to get to SDG 3.4, without averting these deaths, it will be near impossible to reach any goal on premature mortality, certainly for non-communicable diseases. So a few elements that we think are quite crucial to good hypertension control programs, and really this is the essence of hearts. And I'll tell you a bit more about the WHO hearts in a second. But good programs have a simple drug and dose specific protocol. The less branches, the better. As Dr. Marc Jaffe, who I know is also speaking here today, would say, we need to have access to validated BP devices. We need to have adequate availability of the drugs as defined in the protocol. We need to have a team-based approach and use of non-physician healthcare workers. We need to have an information system that can capture the control rates, longitudinal data for the NCDs. And at the center of this entire approach is the patient. It's a patient-centered approach. I also think that hypertension programs should be simple, they should be scaled, they should be institutionalized and integrated, they should be measurable, practical, lasting, and easy. Everything doesn't have to be drama, and everything doesn't need a massive, complicated response. When things are simple, they are simple enough to do. So I'd like to tell you a bit about the new products that WHO has to offer. We have priorities for research on hypertension care delivery. We have the global report, which I referred to earlier. We have a Hearts Partner Forum describing the 11 Hearts Partner organizations. We have non-communicable disease facility-based monitoring, and we have a guideline for the pharmacological treatment of hypertension in adults. This was quite important. It was done in 2021, and really it was 2 decades after the last guidance came out on hypertension for WHO. And really how we see this is that in 2018, we launched the Hearts Technical Package, and here you see the HEARTS. But since then, we have new guidance and we have updated our guidance. And so whilst we maintain the elements of the Hearts Technical Package, you might see it in different ways. For example, the evidence-based protocols, we now have a WHO endorsed protocol as per our guideline in the pharmacological treatment book that was launched in 2021. It really has some guidance on thresholds, some clinical guidance, some very technical guidance, but it also has guidance on implementation. And this is why we're so proud of the document. It's one of the only documents to actually talk about treatment by non-physician professionals, to have implementation remarks, to talk about frequencies of assessment, targeting of blood pressure, and really things crucial to those things that we think are part of a good hypertension control program. To tell you a little bit about hearts around the world, so since the package was actually endorsed, we have been increasing in the number of countries that we've been working, and now we've gotten to approximately 40 to strengthen cardiovascular management in primary care. In our global report, we highlighted a few cases from the Philippines, from Hearts in the Americas, national scale-up in Cuba, and also strengthening supply chain initiatives in India. To date, more than 20 million patients are on a standard drug and dose-specific protocol globally as per the WHO guideline. We are extremely proud of this, and it's part of the WHO results framework as well. In general, the fight against hypertension is an important one, but it's also a condition that really lends itself to a public health approach. And that's why we implore people on going through a programmatic approach, starting small and really beginning with a few champions in your area. As I said before, I don't think that hypertension needs to be complicated. I myself am not a specialist, not a cardiologist. I'm actually a community health physician from South Africa. And I can tell you, even in my own country, we don't know control rates. So things that are important to programs, to scaling up, are the things that we truly benefit from and the things that we consider a public health intervention. I really hope that Canada becomes country number 41 or 42 in our efforts and adopts hearts globally. Thank you very much for your attention, and thank you so much for your time.
That was a fantastic talk by Taskeen. It's my great pleasure to introduce our next speaker, Dr. Pedro Ordunez from the Pan American Health Organization. I will admit I idolize Pedro, his energy, his enthusiasm, and his ability to move governments and people to his mandate. So without further ado, Dr. Ordunez will talk about the effort in the Americas to control hypertension.
Hello, everyone. My name is Pedro Ordunez. I'm regional advisor of the Pan American Health Organization and the regional office WHO for the America for cardiovascular disease. I'm the leading person for the heart in the Americas. Thank you so much for inviting me to this important event to celebrate the 2024 World Hypertension Week. And today I have the opportunity and the honor to share with you the last progress of the heart in the America, which is the main intervention to reduce the cardiovascular disease prevention and control in the America and to improve the control of hypertension. So let me start with this, why we are implementing heart in the America. The first is clear, and many other regions of the world, the cardiovascular disease is the leading cause of death. So this is the urgency. And the hypertension is the main risk factor. And we know very well if we improve hypertension control at the population level, we can reduce the mortality, the CVD mortality, and for ischemic heart disease and stroke. And particularly in the America, we have a very clear number about that. For every 1% of hypertension control at the population level that we are able to improve, we can reduce the mortality 2.9% in ischemic heart disease and 2.4% in the stroke mortality. However, even that hypertension is a very preventable and treatable, the control of hypertension at the population level is not good. It's suboptimal, actually. In the America, about 36% of the people have a hypertension control. And these represent a very big issue for the health system and the society as a whole. And there are many issues related with the access and quality of care that we can address if we are implementing the heart in the America. Let me explain, what we are doing to implement heart in the America. But before to start with the key intervention, I want to start with the number. What is the number of heart in the America at the end of 2023? So we have 33 countries of the America are already committed with the implementation of heart, and 27 countries are actually implementing heart. What means actually implementing heart? 27 countries have a government committee, have a plan action, have a clear idea and plan with the key stakeholders. The country has defined the clinical pathway, the core set of medicine, the devices, and one of the most important, they are selected the primary health facility to implement the program. We have more than 6,000 facilities of the primary health facility implemented the program. Every facility has in between 25 and 30,000 people. And 8 countries have implementation in over 80% of the facility. And 27 countries have developed a clinical pathway. And this is a very big number, 4.5 million persons in treatment and 60% of control. So, but what they are behind this very big number? Well, behind this very big number, there are a clear strategy. And the heart in the America strategy is targeting the health system chain to improve the population hypertension control and CVD risk management. What is the key action to target the health system? The first is promoting the paradigm shift. A paradigm shift included the comprehensive strategy focusing in primary health care, healthcare-based or team-based care, a standardized diagnosis, a clinical power, standardized training and education strategy oriented to the change of the practices of the primary healthcare setting, and system for monitoring and evaluation. Of course, the program to be successful need to have a very clear pragmatic priority. And one of the pragmatic priorities is to increase the number of primary health centers implementing HART, and institutionalize the clinical power and adopt and implement the HART hypertension control driver for quality improvement. So one of the key resources for the HART in the America, and partially explain how successful is the implementation in the region, is to have a clear, straightforward, and simple HART clinical power. The clinical power starts with the accurate blood pressure measurement, a clear protocol to take a blood pressure, and use the blood pressure measurement device, automatic and validated, and the cardiovascular risk approach. And the cardiovascular risk approach, in our case, is very pragmatic approach. It's not to delay the initiation of treatment, which is a mandatory in the America when you have a diagnosis of hypertension, but it's to define the people with a high risk of cardiovascular disease and the people with hypertension without risk of cardiovascular disease. Different target, different intervention. The most important thing maybe at this time is to highlight that in addition to hypertension medication with to the people with high risk, because they have a cardiovascular disease, already have a cardiovascular disease like a stroke or ischemic heart disease or diabetes or CKD, they are classified as a high risk hypertension patient, and they receive, in addition to high blood pressure medication, they receive a statin. This is an important addition to the program that we want to remark today. Another thing is, and this is the core of the HART clinical power, the core of the HART clinical power is the standardized treatment protocol. And the standardized treatment protocol clearly represent one of the most important intervention because it's a simple, it's very pragmatic, it's very, have a very few steps, including pharmacologic and non-pharmacologic treatment, but the pharmacologic treatment with a specific medication and a specific dose and a very simple way to follow all the patient with a hypertension control. So this is one of the critical. HART clinical power is a managerial and a clinical tool for improve the control of hypertension at the community level. So today, 27 countries of the region have this kind of clinical power. 24 countries start with a combination of two drugs for in the first step of the treatment protocol. This is a very big achievement. And 26 countries recommend the use of statin, and 23 have the high intensity dose of the statin for the secondary prevention. The other important component of the HART in the American is the managerial component, or is the component to implement the HART driver for hypertension control through the HART quality improvement approach. In this case, we are selected very clear driver, what is the fundamental action that we need to transform on the health system to improve the hypertension control. Both, the clinical power, the driver are very well aligned with the WHO clinical guideline. And in addition, we have a HART performance index and HART maturity index as a main indicator to evaluate the quality, the feasibility, the fidelity of the intervention, and of course, the result of the intervention at the primary health facility. This quality improvement methodology includes, the review the driver for improving hypertension control, define what is the implementation action at the primary healthcare level, monitoring and documentation and evaluation, capacity building, effective communication, of course, recognition of the champion. This is a quality improvement methodology. Finally, I think that HART in the America is a game changer in the region. So, and one of the key for us is how we can empower and commitment the first level of care. So when you select the primary health facility as the key intervention site, you can define the target population. A program is led by and for primary healthcare provider. It's a very primary and comprehensive clinical approach, capacity building and team-based care, of better access and quality of medicine and validate devices and accountability and informing community. All of these interventions together can empower and improve the commitment of the first level, okay, with the implementation of the heart in America. So this is the main result of Heart in America. I appreciate so much your time and the opportunity to share with you all the resources that we have in Heart in America. So thank you very much for the organizer, and thank you very much for everyone. And happy World Hypertension Day. Thank you.
Thanks so much, Pedro. Fantastic talk. It's important to note that the implementation of HEARTS has been in a diverse spectrum of countries that have much more difficult economic circumstances and more difficult issues in primary care than Canada does. And the program has had really a tremendous impact on hypertension control in these countries. It's my great pleasure to introduce another good friend, Marc Jaffe, who really laid the foundation for the HEARTS program back before the year 2000. He was tasked with improving hypertension control in Kaiser Permanente, Northern California, with a clinical population of over 3 million. And so Marc, I'm not going to waste any more of your time for your talk. Let's hear about how it all started.
Hello, my name is Marc Jaffe, and I'm an endocrinologist in San Francisco, California, and I'm so excited today to talk to you about the Kaiser Permanente Hypertension Program as the foundation for HEARTS. Most of you probably know, but for those of you who don't, Kaiser Permanente is in Northern California. We've got almost 5 million members, almost 10,000 doctors, over 20 medical centers, almost 250 medical offices, and we have comprehensive services, including pharmacy, inpatient, and outpatient services. Most of what I'm going to talk about today was what we published in our JAMA article from 2013, where we described the steps we took to improve hypertension control in our large hypertension program. And a few years later, we published a second paper where we basically doubled the hypertension control rate, and we went into a little greater detail in the second article from the Journal of Clinical Hypertension from 2016. So how did we do it? How do we go from 40% to 90% hypertension control? Well, it took us a long time, but it can be basically broken down into 5 simple steps. Number 1, we had a registry. We created a list of patients who needed something done. And once we had a registry, we needed a metric, a way to monitor our performance. So we created a system for performance feedback. And once we had a list, the registry, and a way to give performance feedback, we needed an effective treatment protocol that was simple and evidence-based. So we came up with that. And once we had those 3 components, we focused on team-based care to make the delivery of those services more effective and more efficient. And of course, we needed to pay attention to medications, and we focused on a single pill combination medicine, which really helped us get hypertension control effectively and quickly and safely. So the first thing we set out to do was to set up a registry. So we went ahead, and in 2000, we didn't have a registry. So we put together a list, a really big list with outpatient diagnostic codes, pharmacy data, hospitalization records, and we would periodically audit the list to see if we had the proper sensitivity and specificity. And eventually the list grew from 350,000 people to about 650,000 individuals. And that went from a prevalence of about 15% to 27%, which we thought was about right because we expected roughly 27 to 30% of adults to have hypertension based on external data. So that was a way to validate that our registry was getting much closer to our true prevalence. So our next step was to come up with a performance improvement metric, and we didn't have one. So we basically came up with one on paper where people would have to write down the blood pressure, bubble in the blood pressure on a form, which was sent to a central processing unit. But eventually that became automated with our electronic medical record. It became a lot easier to get the data. But I think the key point is that we were able to come up with a performance metric using papers which were distributed, and it became much more efficient when we had an electronic medical record. So once we created the performance metric, we had to figure out how to share that with people. And so we came up with annual quality goal targets, and we had unblinded medical center performance. We had a central hypertension management team, which would review the reports and the performance. And we had teams at the local medical centers to help the medical centers come up with innovative strategies to improve hypertension care. We identified the best practices throughout our region, and we held meetings and peer support groups, and we shared the best practices. And we found that the feedback was effective at the clinic and medical center level, because when those centers identify opportunities for improvement, they were able to allocate resources and make system level changes. So now that we had a registry, which is our master list of patients, and we had performance metrics, which was a way to see how well we were doing, we needed an implementation strategy, something to offer to these patients to get their blood pressure under control. So we developed a simple hypertension treatment algorithm, and we updated this every 2 years. We had a very diverse guideline development team with primary care, specialty care clinicians, cardiologists, nephrologists, endocrinologists, primary care doctors, internal medicine providers, pharmacists, methodologists, and lots of others. And we had a great team, and we reviewed the evidence frequently, and we made updates when appropriate, and we came up with a simple, effective treatment protocol. And even though we had access to lots of different medications, we found that a simple protocol, starting with a combination of hydrochlorothiazide and lisinopril, adding a calcium channel blocker, and then adding spironolactone, and then adding bisoprolol, a beta blocker, was really an effective strategy. If you think about it, it's 4 steps, 5 drugs, and almost all patients were effectively managed using this simple hypertension treatment protocol. And yes, it's a little more complicated than that, and I've got a slide here with some of the details, and you can reference this online, but I think the key point here is that we try to take something very complicated and make it very simple. Now, of course, there are lots of advantages to have a simplified treatment protocol. Number one, there's a single specific drug for each step. This makes it easier to use fewer drugs. It improves familiarity and decreases practice variation. It can simplify the use of teaching materials. It allows for more people to be involved in better team-based care, and it may simplify drug forecasting and procurement, and it may promote more favorable drug contracts. And you can see that when we instituted the regular routine use of single pill combination therapy, you can see that our percentage of prescriptions written for ACE inhibitors and thiazide diuretics went from almost 0 back before we started the program in 2001 and 2002, up to about 1/3 of patients in the mid-2010s. And that's a big improvement. We think that's a big reason why we were able to so effectively control the hypertension in our population. When we implemented team-based care and really started to use medical assistant blood pressure visits, this was really helpful as well, because having people come back and see the doctor isn't very cost-effective or isn't very convenient. So when we had people come back and see the medical assistant, We could do it asynchronously, meaning you could come to the medical center when your doctor wasn't around. It reduced white coat effect. At the time, there was no copay. It was very convenient. And specialty departments could send people over to the medical assistants in primary care and get their blood pressure checked. And we trained the medical assistants to do it properly and reliably. You can see that when we implemented a program like this, we were able to move our hypertension control from about 40% up to 80 to 90%. And you can see Kaiser Permanente in Northern California is the blue line there. And this consistently outperforms the other managed care organizations in the state and in the country. And while our hypertension control rates were going up, our rates of heart attack were going down. And I believe in large part, these two were related. In other words, the attention to hypertension control really was associated with the reduction in the heart attacks that we observed in our organization. And here's an article from UCSF where a neighboring healthcare delivery system looked at the Kaiser components and implemented them in a totally different system, showing that the principles that we use could probably be done in other settings as well. And these same principles, which we did at Kaiser Permanente, were published recently by Dr. Campbell and several others of us when we looked at essential components across the globe that could be used to control hypertension in large populations. And you can see from our paper that not only were medications, protocols, task sharing, and monitoring important, but also leadership and screening. Thanks so much for spending 10 minutes with me today. I'm so proud and so excited to be part of the Hearts program, the Hearts in the Americas programs, and to see all the work that everyone has done in hypertension population control coming together and helping people in my health system, in North America, Canada, and throughout the world. Thank you very much.
So thank you very much, Marc. Really an excellent presentation. So you've really seen around the globe from lower middle income countries to high income countries that the Hearts program can provide highly effective care, less costly, more effective, and has brought hypertension control up to 90%, not just in Marc's presentation, but it has been duplicated in Chile and Colombia. Now, from the world, we're going to come back to Canada and Calgary, and it's a real pleasure to introduce Corinne, who's adapting the Hearts program to the Crowfoot Village family practice. Some innovations we're hoping to enhance and spread and scale starting in Crowfoot, but across Canada. And Corinne's done just an amazing job. I will say Corinne's clinic is an amazing clinic as well, and may not be the same as everywhere else, but we can address that perhaps later. Thank you, Corinne, and look forward to your presentation.
Hi, everyone, and thank you to Dr. Norm Campbell for inviting me to speak today. My name is Corinne. I'm a registered nurse and the clinical nursing lead at Crowfoot Village Family Practice in Calgary, Alberta, Canada. Today, I'll be sharing our clinic's experience designing a hypertension initiative from the planning stage through to our current implementation status. I'll be sharing our ground level learnings, including our successes as well as our challenges. My hope is that by sharing our learnings, we can help inform others who are looking toward their own plans. So just a little bit of background. What we know is that suboptimal systolic blood pressure is the second leading risk for death in Canada, so very significant. Our theory at Crowfoot Village Family Practice, or CVFP, is that we may be underdiagnosing hypertension at our clinic. We did find about a 5% gap compared to the Canadian statistics. We also found that just less than half of our adult population over the age of 40 had a blood pressure measured in our EMR, or electronic medical record, in the last year. So there may be a further cohort of patients undiagnosed, missing with that screening piece. So the Crowfoot Hypertension Initiative aims to adopt global best practices in order to optimize hypertension control. A little bit about Crowfoot Village Family Practice. So we're a large family practice with 16 physicians, a nurse practitioner, a physician assistant, 3 pharmacists, and a team of registered nurses and medical office assistants. Together, we care for over 24,000 patients in the Calgary and surrounding area. A little bit of a unique thing about our clinic is our physician funding model. We work off a capitation funding model, not fee for service, which is traditional in our province. So really this funding model incentivizes team-based care and innovation, really, so we can provide evidence-based care and fully utilize all team members' scopes of practice. So getting things started. Back in October of 2022 is when we started the planning phase of the initiative. And what did we need to make this work? That included things such as executive sponsorship in the clinic, governance endorsement, operational leaders at the table, as well as designating a leader for the project, which became myself as we worked through the initial planning pieces. So in October of 2022, we established a core committee with team members from our management group, operations, physicians, pharmacists, registered nurses, medical office assistants, as well as patients. It was important to have the patient voice at the table when designing the initiative, really embracing the idea of patient-partnered care. External experts were also key to the initiative, and so including Dr. Norm Campbell, thank you so much for your ongoing support of the initiative and guidance. From the core committee, we established 3 working groups. So they were going to work on action items in the fields of screening and prevention, diagnosis, and management. So those working groups consisted of members of our core committee acting as facilitators, as well as other clinic team members. And we were then ready to start working on our initial action items. So here I outlined just a few of the initiatives that we've been working on, or parts of the initiative we've been working on over the subsequent months, or now going on almost a year and a half. One thing we developed was a new EMR entry process. This was a key and actually not included in our brainstorm of action items initially. We need to know what we're measuring, and our EMR was not working for us before. So I'll speak to that a little bit in the following slide. We needed to develop staff training. So it's important to have consistency, both with measuring blood pressure in office, as well as entering blood pressures into the EMR, or electronic medical record. We developed a home blood pressure screening guide. So this guide takes patients through measuring blood pressure at home, as well as giving them information about cardiovascular risk and collecting information about their cardiovascular risk factors. We've also developed a diagnosis and treatment algorithm. So consistent diagnostic thresholds broken down according to risk level, and also a standardized treatment algorithm. So just highlighting a couple of these for you. One thing, so our EMR entry system. Prior to the initiative, we only had 1 entry cell for entering blood pressure into our electronic medical record. But these could be blood pressures that were taken as part of vital signs if someone was unwell. They could be readings taken to screen or diagnose or for treatment purposes of hypertension. We really had no way of differentiating that. So after a lot of different iterations and planning, we settled on 3 different blood pressure entry cells in our EMR. So these are highlighted on the slide here, you can see. So we have home blood pressure readings. So this would be the average of a set of home blood pressure readings that a patient sends in. And our staff are trained in how to enter those in a standardized way. Home blood pressure readings have really become a pillar of our hypertension initiative. We're encouraging that where it's appropriate for patients. Evidence supports, home-based reading as a significant source of accurate readings, versus always just going to office measurements. The next entry cells you can see here are what we refer to as AOBP, which stands for Automated Office Blood Pressure. So this would be a set of serial readings done unwitnessed by the healthcare provider. So the team member would set the patient up with a automatic blood pressure machine who would take the series of readings, and then we would be entering the average into those cells. So that would be our gold standard for in-office blood pressure measurement for the purposes of screening, diagnosing, and treating hypertension. The last entry cells, as you can see, are we refer to as acute BP. So this would be office blood pressure taken by a staff member, could be using an automated machine, but it doesn't fit resting criteria, or the patient circumstances aren't suitable for the blood pressures to be used for the purpose of hypertension care. So example, if the patient's in pain, unwell, under stress, things of that sort. So that's what we landed on, and we've started collecting some great data so we can now actually see what types of blood pressures are being measured and how we can best action them. The next slide here, fairly busy, but just wanted to provide a couple quick screenshots of some of our algorithms. So on the left-hand side, you can see our diagnosis table, so broken down into low, moderate, and high risk hypertension, and then the cutoff screening levels that we're aiming for patients, or treatment levels, pardon me. So this helps guide diagnostic and target decisions. On the right-hand side, you can see again just a quick screenshot of our treatment algorithm. So taking us right through from the patient's initial high reading through diagnosis, and then a feedback loop of different medication options as it's suitable for the patient. So looking at lessons learned, we learned a lot through the process, and we still continue to. I think one big thing is you need to look at your basics first. So we realized early on that we needed our EMR to be laid out for more consistent data gathering for patient care as well as for reportability, and that staff needed to be doing things consistently as well. Be prepared to adjust your workflows. We went from an initial 3 working groups down to 2 after we realized that there was quite a bit of overlap between a couple of the groups. So consolidating prevented that overlap from happening. Now we're working on more individual consultation and email communications as we get closer to some trial phases of different parts of the initiative. This was a big learning through the process, be prepared to adjust things. Also, things take time. Really it's about balance, between working on the initiative, keeping things going. The work is important, but also not sacrificing daily duties. All of our team members are involved with patient care as well as other activities. So just looking at that balance and trying to just keep the needle moving however you can. Considering related work and topics. So when we look at hypertension, things that were related, such as cardiovascular risk factors, lipid testing and management guidelines, existing EMR tools, we needed to consider all of those so that we weren't siloing work or developing different tools for different factors that we weren't taking into consideration. And last big thing, keeping measurement and evaluation in mind. So, if we don't know what we're measuring or we don't know how to measure it, then we don't know if the initiatives that we're applying are actually working. So, very thankful for the support of team members who have an expertise in this area to help us with that piece. So just a little bit about where are we now. Our home blood pressure screening guide launched in April of 2024. So we're getting some good feedback back from patients, as well as some great sets of readings that we can use to help inform their hypertension care. Our diagnosis and treatment algorithm is pretty much ready to go with a trial, or we refer to it as a PDSA cycle, plan, do, study, act. So we're close to implementation on that. We're currently working on follow-up and surveillance guide. So we're in draft phases of that. And so once we have a follow-up and surveillance guide ready to go, our hope is that we can do a full PDSA of the initiative on one team this summer, respond to feedback and fine-tuning, and then hopefully expand clinic-wide in the fall of 2024. We're already collecting data as far as blood pressure measurement. And once the whole initiative gets running, we're hoping that we'll have some data to assess our interventions by early 2025. As far as future work, we're working as well on outreach and prevention strategies as far as hypertension management and scale and spread. We're eager to share our work with our PCN partners and beyond, to try to just benefit the groups as much as we can. So thanks again so much for your time. I'll be available in the question and answer period, and happy to connect individually with people as well as you have questions. Thanks so much.
Thanks so much, Corinne. Just fantastic work that you're doing. I will speak that the clinic environment that you work in is just amazing. And if all family practices were like yours, and if they had great leadership like you, we wouldn't need this session right here now. I'd like to move to the next phase of this symposia, and that is trying to put those talks into context. And I'd like 2 different contexts. One is from a family physician and board member of Hypertension Canada who can speak really to both the clinical practice, but also from a national hypertension organization, what this means and what can be done. And that's Kristin. So I don't want to take any more of your time. Away you go.
Well, I want to thank everyone for what just wonderful talks today. And it really puts together a lot of food for thought and makes me excited that, you know, we're going to be able to make a really big difference, I think, with adopting these things for family practice and for primary care. But I think that the days of the physician being the only one that's going to be directing this dance they're over. And I think that we have so many amazing allied health professionals out there, pharmacists, nurse practitioners, physician assistants, nurses, and even our own clinic staff that can really make a difference in patients' improvement in their hypertension, that I think that we have to really get with the program and design systems that will take the burden, quite frankly, off of family physicians and involve the help that's available to get better outcomes for our patients. I don't think that I can only speak for here in Ontario right now. There aren't many family health teams. There are mostly people who are working without these allied health professionals. And I think that's reflecting in our very poor blood pressure control rates. So I think that there has to be a fundamental change in the way we deliver healthcare, especially when it comes to hypertension. And I think from the literature we're seeing, not only in hypertension, but in lipid management, in diabetes management, I think all of these things have to change. And right now, family physicians, and I can only speak from myself and for my colleagues, we are drowning in the ability to provide evidence-based, appropriate care for our patients. And here in Ontario, many people do not have family physicians. They don't have access to regular health care. They go to see walk-in clinics, which is not comprehensive care. And I think that we're really dropping the ball. So I think by implementing these systems where you can have generalized clinics where people can come, and there are lots of people that are going to be treating this with a really well-defined understanding of everybody's role, I think that we can make a better improvement. I mean, I think we can make a huge improvement in our control rates, and that's going to decrease people having really severe illness and morbidity, and keep them out of hospital, which is going to free them up for patients who have a lot more illness. So I think it's a no-brainer from a primary care sort of perspective that this is the kind of care that we need. And I can tell you that physicians like myself are open to that. You know, this issue in the past, we have to work together. There's no, you're the doctor, you're the nurse. That's all crap, if you really want to know the truth. And I think that we have to start to engage people. One other thing I do want to make a comment about, and I'm really interested to hear what other people have to say, is, you know, all of this knowledge and all of this starts in medical school for physicians, and I think in nursing school for nurses and pharmacy school for pharmacists, et cetera, et cetera. I think that the education has to come. We have to start putting these implementation strategies to get people used to it in medical school. And the HEARTS program, especially the algorithms, which are quite simple, should be introduced in medical school. So this is not something foreign, that when people graduate, that they start to say, well, what do you mean I have to work in a team-based approach? And well, what do you mean I have, what's this HEARTS thing? I think that this is essential in terms of education. And apart from educating the ones that are out there, we have to educate the new ones coming up so that they're going to be able to not only implement it, but make it better. So I'm really interested to hear what other people have to say. Corinne, I'm interested to hear what you have to say. Dr. Ordunez and Dr. Jaffe, I'd love to hear what you have to say about how things worked in your own clinics. What do you think? Am I making any sense here?
Okay, thanks so much, Kristin. I think can we shift that off to the Q&A, your last question? I think it's very important that in every country that I've been in, and I think Taskeen will back me up, there's been a strong government leadership in everyone that's worked, and not really at the provincial level, Aaron, although you're going to address that. But it's been at the national level in every country that I'm aware of. In Canada, healthcare delivery is a provincial responsibility, as it is in many other countries. And so Aaron is tasked with really enhancing primary care, bringing it all together in Alberta. And so you've got the last words on this, Aaron. Thank you.
Thanks, Norman. Thanks for having me, and happy World Hypertension Day. It's very exciting to be here. Kristin, I'm convinced that you have a bug in my office, though, because everything you said is pretty much what we talk about every day. So I'm really excited to hear that, and excited that Corinne's here too from Crowfoot in Calgary as well. Corinne, I've heard great things, so it was great to see this presentation as well. So just a couple things from Alberta and things that we're doing. And I think this has been such an interesting presentation specifically about hearts, because I actually think the pieces about hearts could be applied to the entire primary healthcare system. And these are some of the things that, and some of the tools that we actually need to apply to revolutionize the primary healthcare system. Here in Alberta, about a year and a half ago, almost 2 years ago now, we realized, we have a major problem similar to everybody else in the primary care system. And we went forward with a initiative that we refer to as MAPS, or Modernizing Alberta's Primary Healthcare System. And it has really, we released the reports in October. So we released a strategic advisory panel report, and we also released a specific Indigenous advisory panel report as well. So we cover both areas, and we really wanted to make sure there was a focus on the Indigenous side as well, because as you know, all know there's a number of issues there, and ways that we need to get rid of racism and those types of things. But one of the big pieces about our MAPS initiative is really a recommendation that we need a central organization that is responsible for primary care. So out of that, we actually developed a division at Alberta Health, which I'm now excited to lead, but we're actually going to create a dedicated primary care organization. As part of that announcement, we're actually creating a dedicated acute care, continuing care, and mental health organization. So we're entirely refocusing our healthcare system here in Alberta. But I'm very excited about primary care because it allows us to have a dedicated spot. It allows us to focus on some of those major initiatives that you heard talked about earlier. Some of the major recommendations. Team-based care is the biggest piece that we can do. I think that is the biggest change. It's needed for the HEARTS program. It's needed for anything in primary care. Kristin, you talked about, how do we use our full scopes of practice? We were very excited. About a month ago, we released a dedicated nurse practitioner program. Right now, there isn't really a program in Canada that nurses can work to their full scope of practice and be paid similar to doctors. So we just released that program, which has been very successful. We expected we'd receive about 20 expressions of interest, and we're already over 70 expressions of interest for our program. So we're very excited about those things. But I think the biggest thing that I heard today is how do you take hearts and how do you use that as an example and explain primary care? So I know we're talking about hearts today, but I'd love to see that we actually expand that concept of, how, Corinne, you talked about how do you use the existing tools and integrate this into things you're already doing, not necessarily changing all of your pathways and all of your milestones and those types of things. And those are some of the most successful things as we've spread and scaled things in Alberta, that if we can embed into the existing primary care workflows, this does not make it harder. It actually makes it more successful. And it's not another thing that we're adding on to the family doctor or the medical assessment or those type of things. So some of those big pieces. And then what is that infrastructure we need to spread and scale? So Corinne, I'm excited you're doing it. I'm excited you're going to talk to our other primary care partners and how we can spread and scale this. I agree. It kind of seems like a no-brainer. I agree. Kristin, you said that as well. That was my first conversation I had with Norm of, I don't get it. Why do we not have it in Canada? This seems like a no-brainer. So we're very excited. We're excited as we transition in the fall to a dedicated primary care organization, and really pleased to be here today to understand how we can expand hearts, and also how we can take the hearts model and use a similar methodology to really improve the primary healthcare system. So thank you for having me today, and excited for the conversation.
Thanks so much, Aaron. Kristin's going to take over for the Q&A, but I just want to make 2 comments. I was visiting a clinic in Cuba with Pedro and asked the primary care physician how it was going, and their comment was they thought Hearts was sent by God. It made their lives so much easier. Now, I will say there was probably a lot of rocky road to get to that point in changing the paradigm shift, as Pedro mentioned. The next thing that's very important is if you look at the webinar chat, the president of Hypertension Canada has announced that Hearts will be the new primary care guidelines for Hypertension Canada, the thing that they're promoting. And so off to you, Kristin.
Well, thanks, Norm. I really want to thank everybody today. I learned an awful lot, and it's nice to know that primary care is getting a, well, how do I put this? An overhaul, shall we say. And I think that that's a wonderful thing. I think there's always room for improvement. So there's a lot of really interesting questions in the chat, and I open this up to the entire panel. Please feel free to just jump in and tell us what you think. So there's a lot of questions here about implementation and how things would work. So for example, one of our members is asking us, in a population-based model of hypertension control, how are you going to identify and treat more complex cases, such as true resistant hypertension and screening for primary hypoaldosteronism? So can somebody speak to how you would weed out some of those more complex cases?
Marc, I wonder if you might address that.
Sure. First of all, great. It's great to be here and hear all the great comments and the great questions. So that's a fantastic question. I think whenever there's a protocol, and this applies to primary care or any place else, I think the protocols really apply to most patients, but not all patients. And just so that you all know, in many places I've visited, and yes, I've been to Cuba with Norm, and with Dr. Campbell and Dr. Ordunez. I think let's just talk about implementation, because when you tell people, hey, we're using a protocol and it wasn't taught in medical school, it can be sort of scary. And I think there's a sense of grieving and loss about, hey, what about my autonomy as a clinician? And so I think it's really important to say, hey, this protocol works great for almost everybody, not everybody, but almost everybody. And let's make sure we apply this to most patients. And when people ask me about secondary hypertension, resistant hypertension, I actually avoid the question. I flip it around and I say, you know what? Absolutely, it's a great question, but let's talk about the 95% of patients that don't have resistant hypertension. Let's talk about the 95% of patients who if we just applied a standard treatment, simple, effective treatment protocol with our whole team, could probably get them under control. And those who don't, yes, there's always be room for the 10 or 20% of people that need specialty care. Because in many places we visit, people are not getting any care, not any care, people are getting less care than they might need. And my personal belief is that as an institution, we spend too much time worrying about those patients that might have something strange, when in front of us, we have all those people with something ordinary. So if the protocol's not working, sure, of course, do a workup or send them along. But I always flip, and you'll get this question when you're implementing. Like, what about these unusual cases? And they're great questions, but I would, as implementers, take that opportunity to flip the table and say, yes, but what about all the regular patients who really they deserve our attention, and if we could give them something simple and straightforward and team-based, it would probably work. And that does seem to relieve some fears about, hey, what am I going to do as a hypertension specialist? Mm-hmm. And primary care usually says, bring it on, give me a protocol, absolutely. Specialty care says, what about the exceptions? And thank goodness, throughout the world, primary care takes care of most hypertension, because I believe they do a better job than the specialist said as a specialist.
Listen, God bless you, but I remember when I was in medical school, I was taught that if it's white with black stripes, it's probably a zebra. And I think that that's what you're trying to say here. And I think that within these protocols, which is quite lovely, there are checks and balances that if things aren't working, that you're moving on to the next. And that goes into our next question. A couple of people have asked, In terms of these algorithms are not written in stone from what I understand in the Hearts program. Everybody can make their own treatment protocols based on availability and based on evidence-based medicine. Can one of you speak, like Dr. Jaffe or even Corinne, because I know that you guys made your own algorithms. How do you change that from one place to another?
Sure, yeah.
Pedro oops, sorry.
Oh, sorry, Norm.
Go ahead.
Just really quick, the thing that came to my mind is even the terminology that we use both internally and patient facing. So we've actually started to shift some of the languaging at Crowfoot away from the idea of protocol, although of course medically when we're looking at diagnosis and treatment, these are algorithms, but more toward the languaging of care plans or clinical frameworks, clinical decision-making tools. And I think that helps both from the patient partner perspective. They're thinking of it as it's part of their plan. It's a framework that we use to make decisions versus a really directive. You must do this, you mustn't do this. So I think some of that languaging was helpful, when we were looking at our patient partners and, how they would want to be approached, with discussions as well as with our teams. Also, when we're looking at allied health professionals like our nursing team, our medical office assistants, our pharmacists, we all have different scopes. And when it comes down to the idea of, say, medical diagnosis and prescribing, there may be different languaging associated with that. Whereas when we're looking at our nursing teams, the idea of a clinical framework, there's a lot we can do within our scope of helping manage, hypertension that, still fits within what's appropriate for our profession. And we can be, like you had mentioned, Dr. Terenzi, taking that kind of load off the physicians. There's so much we can do as far as teaching, follow up, and using those care plans. But yeah, so that just a little, mention that sometimes that languaging can help shift our perspective and help everyone get on board with that idea of team-based care.
Taskeen and Pedro have a lot of experience with people with different algorithms and promoting one or another.
Taskeen, you first or me first?
Go first, Pedro. You have the floor.
No, well, I think this is a very good question. I think that when you have a regional approach, is one of the key to implement the standardized treatment protocol. So that's why we're moving from the simple standard treatment protocol to more comprehensive clinical pathway, include all the kind of thing, for the primary healthcare level, right? So based on the because maybe this is not a problem for Canada, for many low middle income countries, the government, the Ministry of Health need to decide what kind of medication they have, And the one thing that we are working with the country is what medication you have, based on the medication you have, you can start, the approach is the same. Combine two drugs with different classes, and define the clinical pathway. But when you have a regional approach, the country approach with the regional, it's most easy to understand the process. Actually, the more we found some resisting at the beginning of the program for the very specialized size, the specialized like Marc Jaffe, but not really, but the people that is a super specialized person, However, the family physician, the primary healthcare team, they are happy to have a clinical pathway because it's not only the clinical tool, it's a managerial tool, it's a procurement tool, it's a, it's a quality improvement tool. It's in many ways, it's very practical and it's a, very easy tool to everyone. So the region have a regional, and that's why we have 33 country commitment in the region. Can you imagine, under these circumstances in the region of the America with the diversity of the country, different level of development, different culture, different things, how we can have a clinical power? Of course, every country have a capacity to decide what medication they have, based on their own, availability. But the approach is quite similar. This is one of the secrets.
I like passionate people. That's fantastic. Dr. Khan, what do you have to say about this?
So maybe just practically speaking, when we developed the hypertension guidelines, the WHO hypertension guidelines, one of the things we did in the algorithm was make a little asterisk so that you could change and you could replace whatever you wanted in place of. So for example, our algorithm starts with amlodipine, and we have one for a combination pill as well, but we've got a little asterisk to say start with anything, either a calcium channel blocker, an ACE inhibitor, or an ARB, depending on what you have in your country. But make sure that you have just, a simple drug and dose specific, and that you follow a flow chart that doesn't go more than 6 steps. So I think that was the rationale and the messaging behind it. It's not so much what agent you choose, but it's rather that you can replace from other classes. And we've seen it to be quite successful. There's some countries, most countries, I must admit, go with the calcium channel blocker, amlodipine, but some choose, others, some choose ACE inhibitors. So, I mean, there's a difference, but that's perfectly fine for us. Thanks.
That's excellent. Thank you so much. And we have time for one more question very quickly. There seems to be a lot of questions in the chat about assigning roles in these clinics as to who's going to do what. Have you noticed that this is a challenge, or do you find that there are that this is a seamless kind of approach? What have you noticed? Corinne, what do you think?
I think at Crowfoot, we have been doing team-based care for quite a long time. So I think a lot of this, we found the process really was just standardizing what we already do. So I think when we look at the idea of team-based care, yeah, it's breaking down everyone's scopes and really who is the best fit for the different types of interactions. So say for an initial diagnosis, and prescribing, they would be, meeting with the family doctor, whether it's in person or, virtually to go through that, or receiving that information from the doctor, but then the registered nurse could give the patient a call and go through things. So it's looking at where do those scopes overlap, and where are there differences, and who is best suited for each step. So I think because we are fortunate enough that we've already had practice at that, it was more just sort of adapting what we're already using. But yeah, I think if it's a breakdown and having all the team members at the table, when you're talking about the initiatives and what each can be doing, it really helps outline where the different scopes are best suited.
Yeah. I could see a real role for, lots of new nurse practitioners, and, extended care could come in and do that, and, perhaps work together with the physicians later on if there's something that's not working well, or, set up a system like that. But you found that was fairly seamless though, correct?
Yeah, absolutely. And I think all of it comes down to the ability to communicate. And so, having an electronic medical record so that, you can be asking questions back and forth, and then also having times to meet together to discuss cases as you need, both on an individual level as well as a larger, strategy level on what's working and not, to be able to fine tune, really sort of staying, engaged together so that, you can pivot things as you need to. Because sometimes the initial way you think things might work, turns out there might be a different way that it'll work better.
Well, I think we're very close to the end of our presentation here today. So I really want to thank everybody who was online today, as well as all of our presenters. I've learned so much, and I must tell you, I'm very excited to be part of this, and I promise to bring this message to Hypertension Canada, and in my own way, push things along as best I can. I've been known to be very persuasive. But having said all of that, I really want to thank everyone for being here today. I think we've had a really good discussion, and it's my hope that we're going to be able to improve hypertension control across Canada. Historically, this has been difficult to do, and I think that the HEARTS program gives us a real shot at doing a much better job in the future. With the abundance of guidelines and the pressures on primary care right now, I think that this program gives us a simple, implementable an effective solution to help us make decisions on a daily basis for patients who are living with hypertension, and in the future, maybe even with diabetes and cholesterol and all sorts of other diseases. So as primary care lead for Hypertension Canada and soon to be guidelines committee member, I'm going to do my best to get these guidelines integrated into our own Hypertension Canada guidelines. I think that we have a real opportunity here to improve the quality of life of our patients, keeping them out of hospital and keeping them healthy and active. And that's going to improve access to other care in our hospitals by reducing that amount of disease. I'm confident that we can do this, people. And I know that primary care in Canada is dedicated to their patients. And I think that they're going to embrace this for the sake of not only their patients that they look after every day, but for their own quality of lives. So it's going to be, I think it's going to be easy to do for primary care who is working in a busy clinic. These are very implementable guidelines. So I'm encouraged that Hearts has shown tremendous results all over the world where it's been used. And I know that Canada is going to be able to do it as well. And I'm going to challenge us that we're going to do it even better, perhaps. So stay tuned. You're going to see more from us in the Hearts program in the future. If you're interested in learning more, please look up that Hearts program and see for yourself the beauty and simplicity of the algorithms. And perhaps those listening today can get a head start on the rest of the country. So we really look forward to talking with you again. Norm, anything that you need to say in the end? You're muted.
Sorry about that. I just want to thank all the speakers and panelists and attendees for their contributions, and a happy World Hypertension Day to everyone. Thank you.
Go out there and treat hypertension, people. Bye-bye now.